I was asked to speak tonight was because Joe Hooper contacted me after the bushfires. And it's a very interesting time, I think, to reflect on what we've learned about PTSD and its relevance to health generally and psychiatry. And I think disasters are one of those times that really bring this issue into focus. And look, I think the other important issue here, it's not just about PTSD. I think in dealing with traumatic events, you learn a great deal about threat appraisal. And I think one of the things that we can be very grateful for, if you can, in the middle of a disaster, is that I think the bushfires, fortunately, I think, made our governments alert to the risk and respond in a timely and rapid way, which otherwise mightn't have happened. So, I think sometimes out of adversity comes good. And I think we've been spared some of the horrors that have occurred overseas with the COVID-19. And, what I'm going to talk to about tonight could have been very relevant to us, I think, particularly health professionals, if the COVID epidemic had taken off here. And look, I realise it's not just GPs tonight. There are nurses, midwives, physiotherapists. So I'll try and make sure that I include you and your areas of interest in my comments tonight. Now, what I was asked to talk about was to discuss the issue of assessment management of people with PTSD. And look, in some ways that seems like a very dry topic, but what I'd like to do is to actually give you something of the history of PTSD, so you understand really the struggles that it's had sort of finding its place in psychiatry and health more generally. What I would then like to do is not directly to make a lot of emphasis about the role of the GP, but in one sense, the GP has got to be front and central about post-traumatic stress disorder, because it's not actually the condition. It's that as health practitioners, you're dealing with the people who've had accidents, have been the victims of violence, have been the victims of disaster, the people who've had coronaries, the people who've had very problematic deliveries. So it's actually identifying those events and seeing those people as being at risk in the future. The final point that I was asked to talk about was referral pathways. Now, I think one of the great tragedies actually is the lack of coordination of services that there are for people with traumatic stress, because if you think about the emergency services, every emergency service sits under a different minister and they have different health systems. You have Department of Families and Community Services who are dealing with children who are the subject of abuse and neglect. You've got corrections dealing with people who often have very traumatic histories. You've got health dealing obviously with accident victims. You've got the Department of Veterans Affairs. I could go on, but you can see that there are multiple different health agencies and bureaucracies that deal with this. And one of the failures is, I think, to actually coordinate and bring those services together. And I think often those issues come to attention at times of disaster. And the current Royal Commission, I think very appropriately, is actually looking at the inability to really aggregate knowledge. And one of the other real struggles that I think we're having in Australia is that previously the Department of Veterans Affairs and the repat hospitals were a key resource in this field. And essentially DVA has become a health insurer and believes that the services it needs are in the community to be purchased. And that just is not the case. As with any area of medicine, we need specialist services and centres of excellence. And I think there's been a fundamental failure of state and federal governments to recognise those and properly resource them. So there are no properly funded state clinics, for example, for post-traumatic stress disorder. There is the Jamie Larkin Centre for Veterans, but that only serves about half of the veterans community in South Australia. So, look, I think that's one of the difficulties. There aren't simple referral pathways, but I'll make comments about that as we go through. Now, to go back to the beginning, the events that really hung over the 20th century and had a huge effect on this field was World War I and World War II. And prior to DSM-3, which was published in 1980, which included post-traumatic stress disorder, in DSM-1 and DSM-2, you'd had growth stress reaction and then adjustment reactions. Now, behind that idea was that the only effect that stress had was acute reactions. There weren't long-term disorders. But in fact, there was a very long tradition of understanding about those. But in 1916, there'd been a conference of German psychiatrists in Munich, which essentially rejected the idea of traumatic neurosis because it was seen to be undermining the German nation. And I think it's very interesting to go back and look at what the history of traumatic neurosis was before that. But before I do that, the residual rump of these disorders in DSM-1 and DSM-2 is what we still have, which is adjustment disorder. Now, I know it's a diagnosis that's very often used by psychiatrists and in general practices, but I think it's a diagnosis which actually is very poorly understood. And essentially, it's at the bottom of the diagnostic hierarchy, and it's the diagnosis of last resort. The first thing is that if you have any other disorder and have ever had any other disorder, the diagnosis of an adjustment disorder really is redundant. It is a disorder that obviously begins in the immediate aftermath of stress, but it doesn't define any particular symptoms. And one of the difficulties of it is that it assumed that the level of distress is greater than otherwise would have been the case. And I think one of the problems is that we are not good at actually knowing what the normal reactions to stress are. And one of the privileges for me of both being a clinician and being involved in epidemiological studies of disaster victims, military personnel, accident victims, is that the significant majority of people can have the most horrendous things happen to them and still sleep the next night. They don't have difficulties with their memory and concentration. They might be distressed, but they don't have what we could call symptoms. And as a consequence, I think sometimes it's very difficult to know what is a normal reaction and what is an abnormal reaction. So, I think the important message about adjustment disorder, before you use that diagnosis, make absolutely sure the person does not have depression. So often I'll see people who've been diagnosed with an adjustment disorder, which really they have a major depressive disorder. And as a consequence of using an adjustment disorder, they get very poorly treated. The other thing is it's a diagnostic category that has virtually no research into it. So there's very little information about its treatment. So look, it's an easy diagnosis to make, but one that really isn't underpinned by knowledge. So I would request that you try and sort of avoid that if at all possible. Which really brings me back to the whole issue of PTSD. And as I said, look, this is not a new idea, but it's been very vulnerable to political and social forces. And I'll just quickly walk you through that. I mean, I'm not sure if anybody recognises who this gentleman is. It's Otto von Bismarck, who was the German Chancellor who unified the German states to make the nation of Germany. And one of the things that he had to do was to actually bring the socialists into his coalition. And the way he did that was by acknowledging that there would be compensation for accidents, whether they be in the workplace or from travel accidents. And the major source of travel accidents at that time were railway accidents. And what the medical profession was fascinated by was the physical symptoms that people got, but they then came to realise that it wasn't because of the deceleration injuries, it's the old whiplash question, but largely because of the nervous shock that people suffered. And that led to Oppenheim in 1889 defining the term traumatic neurosis. And the interesting thing was that in World War I and World War II, this was really discarded for political and nationalistic reasons, rather than any questions about its validity. And as I said before, there was this whole concern that if you made diagnoses, it was seen to undermine the fighting spirit. And that was one of the reasons there was such a focus on acute reactions and not having diagnoses about long-term consequence, because it was felt that if you said somebody had a problem, that would be a self-fulfilling prophecy because of the whole issue of suggestion. And, if we look at the way that the history of PTSD and war was conceived of, these people were highly stigmatized during the conflict. They were seen as being cowards. They were malingering. They were developing symptoms to remove themselves from combat. In the aftermath, it was seen to be suggestibility, exaggerated disability, and compensation neurosis. The issue of compensation reached the point where in 1938, the English decided there would not be pensions for psychological injuries after World War II. And I think it's worth thinking about these issues because many of those beliefs, I think, still very much dominate the insurance industry and their thinking. And I think there's an enormous amount of stigma that remains about traumatic injuries. And it really is an aftermath of those sorts of attitudes. And I think it sort of shows how lingering prejudices can be. So really the legacy was that that stress has acute effects. The way you deal with it is by acute interventions such as crisis intervention. Crisis intervention came out of the military. You should get people back to function as quickly as possible. You minimise the use of diagnosis. And they also saw the predominant reason why people developed symptoms was because of vulnerability and developmental factors. So it was really from that background that there was a whole campaign by the Vietnam veterans and the women's movement to really say that there was a gross mistreatment of generations as a consequence of that perspective. And just one example of this was that in World War II, in Bomber Command, a tour of duty was 30 missions. And the reason why it was 30 missions was because you had a 50% chance of being shot out of the sky after 30 missions. Now, if you developed severe anxiety that stopped you from flying, you were diagnosed with lack of moral fibre, you were stripped of rank and dishonourably discharged, which gives you an idea of the degree of stigmatisation. So once PTSD got into DSM-3, the critical issue was, well, how do we define it and how do we diagnose it? Now, one of the things that I think is really important is that you really do have a clear idea of the diagnostic criteria, because and I see this with psychologists and psychiatrists. They often will make the diagnosis or exclude the diagnosis without properly going through the diagnostic criteria. Now, I think that's very difficult in a general practice consultation because you simply don't have the time, but it's worth having a clear understanding of what the diagnostic rules are, and if needs be, make sure that it's pursued. Now, I'll go through these in order, but there are a whole series of domains that are set out in DSM-5, and I'll go through these in turn. Now, but before I do that, I think one of the other big mistakes that we make with traumatic events is that we forget that if a member of the public is involved in an accident today, or there's another, let's say there was an earthquake in Adelaide tonight, not everybody who becomes unwell after that earthquake is starting with a clean sheet. The National Mental Health and Wellbeing Survey showed that 20% of people in the previous 12 months have had a psychiatric disorder. PTSD was, in fact, the most common disorder in the last National Mental Health and Wellbeing Survey. So that there'll be two groups after a traumatic event. There'll be those people who've got a disorder that may be made worse or modified as a consequence of the incident. The second issue, there'll be a new group of people who will get other disorders. And I think often in the discussion about how to manage the consequences of accidents and disasters, we miss that fact. So this is really just sort of summarising. If you look at the population and a traumatic event happens, there will be people who've got pre-existing disorders. There will be a group of who develop PTSD because of the recent event, but there'll be a group of people who've got PTSD because of previous events. And the other important issue that I won't talk about tonight is that depression and anxiety disorders are also very common after traumatic events. PTSD is, in fact, only one of the disorders that occurs in this setting. And I think that's another important thing that we really have learned, is that trauma has a very significant footprint in terms of the morbidity that it causes in terms of psychiatric illness. Now, just to make this point in a graphic way, this is a study that was done by a PhD student of mine, Xiao Hua, in China, where she studied an earthquake. And what she did was to study 4 villages, one that was about 500 miles away from the epicenter of this earthquake, and then there was a mildly affected, intermediately affected, and highly damaged village. And you can see that more than half of the morbidity, even in the most damaged village, you could have probably attributed to disorder that had been in that community, using the control village as the marker of that, which highlights that when we do need to think about, well, what does somebody bring to an event? Not everybody brings a clean slate, and it does require different strategies. The other important issue, for example, after bushfires, we know that people who've got existing disorders are more likely to seek care, and so the really difficult group to get to are often the people who haven't had any experience of negotiating their way into care with their GP or into the health system. And so I will be trying to talk about that tonight. So the first important thing about the diagnostic criteria is the stressor criterion. And this really essentially is the gate that you've got to get through before you ask all the questions about the symptoms. And this is an issue that is subject to considerable debate and controversy, particularly amongst the legal fraternity, because there are all sorts of benefits that can come if you can get the diagnosis. And essentially it's being exposed to actual or threatened death, serious injury or sexual violence. And then you'll see that the criteria list a number of ways in which that can happen. Now, in one sense, this absolutely defines why general practitioners are so important in this field, because you will see the person who's had the motor vehicle accident. You'll see the person who had was seriously assaulted. You'll see the person who was in a house fire. You'll see the person who's been the victim of domestic violence. You'll see the person who's had a coronary and had a cardiac arrest. I mean, I've seen patients develop PTSD from being resuscitated with a cardiac arrest. People who've had accidents, for example, sometimes are so terrified about the treatment that they've received in hospital that they cannot go back into hospital, because the memory of the trauma is not so much about how they finished up in hospital, because they might have had a head injury, but about the pain and sometimes delirium they experienced in ICU. And look, I think another really important part about this stressor criterion in the context of the COVID-19 pandemic is, look, and I think we've been fortunately, as I said before, spared an enormous impact of this in Australia. But talking to colleagues in the US and actually talking to Sal Hua, the doctor who did that study of the earthquake, this pandemic has taken a considerable toll on doctors and nurses working in those frontline hospitals, because they have had to deal with not only the death of their patients, but the personal threat to themselves and the threat that might pose to their families. So in terms of GPs' roles, the point is that as soon as you identify somebody who's been exposed to an event like this, it's almost like you should put a red sticker on the front of their folder and say, this person is somebody who I need to follow and look for symptoms. And I'll walk you through those. So I think one of the important issues here is, well, how's the trauma field changed? I mean, interestingly, when this DSM-3 was originally published, it said that these are events outside the range of normal human experience. And the fascinating thing is, epidemiology has taught us that, in fact, these are actually far more common events than people anticipated. Now, one of the studies I did after Ash Wednesday was a group of children in the southeast, and we followed them up with a control population. We followed them up 21 and 28 years after the fire. And what you can see here is just how common these different traumatic events are. Life-threatening accidents. You can see nearly a quarter of the population have been exposed to these. Seeing somebody badly injured or killed, another 25% of people. The rates of sexual molestation and rape are, remarkably high in the Australian community. Serious violence is significant. Being threatened with a weapon. So, I think we have previously, I think, completely underestimated how frequent these issues are. And in fact, if we look at the control population who hadn't been exposed to disaster, you can see a quarter of people have experienced 2 or more of these events. So this is far from being outside of the range of normal human experience. And you can see the list here. That's almost a list that you need to have in the back of your mind And if you think that somebody may have PTSD, or you see people who fall into these categories, they're the ones that you need to be contemplating in this domain. The other interesting issue is that the diagnostic criteria, through that stressful criterion bracket, would have you believe that these events are independent of each other. And what we're in fact finding is that that's not the case. And again, looking at that sample of kids we followed after Ash Wednesday, you can see your probability of PTSD, if you've had 4 or more events, goes up to about, the probability of getting the disorder goes up to about 15% after 4 or more traumas, in contrast to really being down around just over 5% after no trauma, after one trauma. So, and this is shown again in this graph. We did a study of the entire Defence Force, and you can see the number of traumatic events is along the x-axis, and on the y-axis, on the vertical axis, you can see PTSD symptomatology. And as you increase your number of traumatic exposures, you progressively recruit symptoms of PTSD. So people don't get used to these events, and this is absolutely critical for the emergency services. There is a limited amount of exposure people in those professions can have, and I think it's very poorly managed in emergency services, particularly the police and ambulance, because these are not careers that you can necessarily have for a lifetime. I mean, this is also an issue for some members of the health professions, people in emergency and trauma fields. Do sometimes become really very affected by what they have seen and had to manage. So the whole issue of assessment. Look, the first thing I would say is, one of the things I so often see with reports about patients is clinicians spend 5 pages writing down the details of what actually happened in the event, rather than people's symptoms and phenomenology. Look, I think you just need to know the event has happened and its key events. Sometimes it's very difficult for people to go through the details. The critical issue is what has changed in the individual. I think another really important issue is the meaning of that experience to the individual. Whether it be the loss of control, or people who've always felt extremely competent, to have panicked, can sometimes be absolutely humiliating for themselves. So I think it's not just the details are critical. And I'll keep coming back to the issue of somatisation, because that's an absolute sort of cornerstone, I think, of presentations in general practice, and needs to be viewed. Now, the first set of symptoms that people get, and I won't go through these in detail, are the intrusive memories. Now, it's fascinating how, since PTSD was included in DSM-3, that this has really become the substance of movies. Every second movie's got somebody who's having flashbacks or recurrent memories. The whole issue of traumatic memory has suddenly become very much part of sort of modern culture. We understand that people have nightmares about these events. Now, the point is, you only need one of these 5 symptoms. What I'd like to focus on is the last 2, which are the intense psychological and physiological distress, because essentially these are triggers. And I think these are ones where often people don't understand the link between the trigger and their reaction. So quite often these people will be diagnosed with panic disorder because the significance of the environmental trigger won't be understood. For example, a patient I saw yesterday was an ambulance officer, and he had claustrophobia. And had been diagnosed with claustrophobia. Now, why would an ambulance officer be diagnosed with claustrophobia? Well, obviously there are many circumstances. This man had several accidents of this type where, you have to get inside a vehicle that can be in a very precarious circumstance, and you're trying to resuscitate some horrendously injured individual, and you are at risk yourself of not being able to extricate yourself, for example, if the vehicle catches on fire. So, one of the really important issues is to try and sort of think about what might be the type of characteristics of the trauma that might provoke the anxiety in the person. I mean, I'll never forget one patient I saw who had been buried alive in, he was working on a site, actually at Wallaroo, where they were building a marina, and they were putting a huge pipe to allow the tidal flow under the breakwater, and the sand wall collapsed on him, broke all of his ribs down one side. Now, he presented with incredibly severe sleep disturbance. Well, sleep disturbance is one of the symptoms of PTSD. But, you know, he'd seen a series of clinicians before he came to see me. But the fascinating thing was his sleep was actually a trigger for his memory of being buried. Firstly, he couldn't tolerate lying flat because it reminded him of the posture of what it was like when he was buried. Secondly, any pressure on his skin, such as a blanket, reminded him of the pressure of the sand. He couldn't close his eyes because darkness would remind him of being buried. So you can, and the other thing is that, you know, if you think about the word when you go to sleep, it's falling asleep. The sensation of falling into the trench was something where every time he fell asleep at night, he would wake with a huge startle. Now, he had no awareness of those triggers that were being activated by the sleep process and getting into bed and lying down. So one of the critical things as clinicians is to try and ascertain and think through about what might be the subtle reminders. They can be smells, sounds. I mean, I think one of the really fascinating things about whiplash, for example, is that one of the main memories, I mean, I'll never forget seeing a patient who had a head-on collision at 120 kilometres an hour in an excellent car. He was driving out on Eyre Peninsula, and this car came around a corner, literally rolling on the side, straight into him. He got out of his vehicle, didn't even lose consciousness. Now, he had, you know, obviously, airbags, all of the modern safety features. But you can see one of the key memories for him of that accident would be the extraordinary deceleration. And any movement of his head is likely to be a trigger for that memory. It's a sensory memory. People then try and stop moving their head because it's a memory for them of that movement. So I think, you know, for physiotherapists, I think it's a very important issue. I mean, I'll never forget a patient who was involved in an accident under the Goodwood bypass, and she escaped a truck that the guy had road rage and was crashing into the back of her. She turned left. Subsequently, she could not go to work turning left because the sensation of turning left would bring back her anxiety. So these are critical things to understand because often the conscious link to the accident or event will not be understood by the patient. So, as a diagnostician, you have to be a detective. The other really important issue is that traumatic memories are far more common than PTSD. This is looking at that sample of kids we followed up after Ash Wednesday as adults. And you can see that 63% of them who had a traumatic memory, a traumatic event, continued to have a traumatic memory. Interestingly, only 12% of them had met the criteria for PTSD. What we were able to do, because we'd followed them up over 2 time points, was to move all those people who'd had a prior disorder. And what we could show that if you've got a traumatic memory related to an event, you've got nearly a 5-fold increased risk of later depression. Not PTSD, later depression. Having a traumatic memory is not good for you. And for anxiety, you had nearly a 4-fold risk of developing anxiety. So often people have traumatic events, they'll be left with an intense preoccupation that will go on for a very long time. And it leaves them at risk of developing both anxiety and depression. And I'll talk about why that might be at a later time. So this whole idea about identifying whether people have a memory of an event and the triggers is a fundamentally important thing to understanding what PTSD is about. Now, the next set of criteria are the avoidance criteria, and you either shut out the thoughts and memories or the external reminders. Now, these are obvious behaviours, and people will often report them. Particularly not like going into supermarkets, etc. Look, and one of the other important issues there is that sometimes these people get diagnosed as agoraphobia. But if you've been violently assaulted, you can't cope being in crowds because anybody behind you will trigger your anxiety. Look, I think these are the least difficult symptoms to ascertain. The only problem is that if people don't like talking about it, they don't tell clinicians. So, that's one of the other challenges, I think, in the diagnosis is actually that people will do everything at times to hide their symptoms. Now, the next set of symptoms are the alterations in cognitions and mood, and there's 7 of these on those 2 slides. And look, I won't go through them in turn, but the important thing is that these look very, very much like depression. Now, I have a real problem, to be frank with you. I was involved on the DSM-4 subcommittee in the DSM-4 criteria for PTSD and had some input into DSM-5, but the cognitive behaviour therapists have really hijacked these criteria and essentially written into the diagnosis what they like treating, which I think is going to bias the treatment literature. But essentially, these are about distorted cognitions about the cause or consequence of events. But you can see that they very much look like depression. If you look at symptoms like diminished interest, persistent negative emotional states such as guilt and shame, well, these are very much sort of part of depression. So it should be no surprise as well that depression is a very common comorbid disorder with PTSD. But I think one part of this set of symptoms, which is not well explained here, is numbing. Now, one of the fascinating things is that there is a subgroup of people where rather than having this lack of executive function, which is essentially controlling your amygdala activity, there's a group of people who have excessive regulation of their amygdala. It's like they put the brakes on completely. And one consequence, you need your amygdala and your hippocampus engaged in your involvement with your environment. That's how you recognize faces, where emotional engagement comes from. And if, as a consequence of being traumatized, you have this excessive upregulation of those frontal systems, you become numb. And one of the interesting things I came to understand, in fact, that many patients who cut themselves because they feel numb. It's worse not to feel anything than to feel. You almost need to feel pain. So the important issue is that quite often these people will be diagnosed with depression because they'll present with this constellation of symptoms rather than speaking about the memories or the anxiety. Now, the final set of symptoms are the hyperarousal symptoms. And I think these are of particular importance because we know these are the symptoms that are most difficult to treat. In treatment trials, people may be left with a significant improvement of their symptoms, but often the irritability, the difficulties with concentration, and the sleep disturbance are residual symptoms. And I think really contemplating how we might better manage these symptoms, I think is one of the challenges into the future. I mean, an interesting treatment which is now being trialled with success and in placebo-controlled trials actually is stellate ganglion blocks. Because it really controls the sympathetic overdrive. And I think sometimes we focus too much on the cognitive and sort of cortical issues in PTSD, but there's some very important research coming out now about fundamental disruption of brainstem systems, including vestibular systems in PTSD that really drive these symptoms. These are very reflexive phenomena about how people organise and respond to threat. And people with PTSD are not only overreactive to traumatic events, they're also very overreactive to non-specific threat. So the duration issue, you have to have the symptoms for a month, you've also got to be impaired. That's obvious. I said before, there are other trauma-related disorders. Don't forget that not everybody has to have PTSD. They may have depression, panic disorder, and I'll speak about that a little more in the moment. I mean, another important issue is the one of substance abuse. There's very good evidence that people who develop PTSD use alcohol, particularly, and amphetamines is the other one, and they actually do work. I mean, people drink for a reason, and there's some evidence that people who drink. In fact, there was one of the first controlled trials that was ever done was done in the First World War, which showed that if you had a tot of rum before you went over the top in the trenches, and you got injured, you were less likely to get shell shocked than if you didn't have your tot of rum. We published a paper on accident victims showing this. If you're a moderate drinker and you had an accident, you've got a significantly better outcome than if you don't consume alcohol. That was one of the papers which was reported very widely in the international media, including the media in Ireland and Zimbabwe, fascinatingly. The other important issue here is that, there's a relationship between alcohol consumption and drinking in the population. So for every additional traumatic event, the frequency of heavy drinking in both men and women increases. So, one of the things to advise patients, I think, after these events is not to increase your drinking. Look, moderate drinking is not bad for people in these circumstances. So it's watching people's drinking behaviour. Interestingly, there's another group of people who, after trauma, get a dysphoric effect from alcohol, and they'll stop drinking altogether. But this is something that I think is very important to watch for. Now, just to sort of really summarise at this point, I think one of the problems is that often patients won't speak of their distress. People, particularly if they're numbed, and I'll talk about the somatic presentations in a minute. The numbing may be the dominant affect, and equally their avoidance is another issue that I think makes it difficult in clinical settings to identify what's going on here. And look, even in clinical settings where clinicians have got a high index of suspicion, this is a study that was done some years ago, but they actually looked at clinical diagnoses as against a group where there were structured diagnoses used, and there were another 14% of cases picked up in 100,000 patients, in 1,000 patients, which hadn't been picked up by the clinicians. So even clinicians who've got a high index of suspicion, they've got know that people are going to be auditing their diagnostic practice. This is a diagnosis that often gets missed. And it's one of the reasons why you really need to hold those diagnostic criteria in your mind. I mean, clearly you haven't necessarily got time to run through them all, but it is having a general sense of whether that pattern of morbidity exists, because people do miss it. And that's a very important thing to be aware of. Now, look, I think I might just stop at that point and see if there are any questions before I go on.
So, Professor McFarlane, somebody asked the question of, sorry, I just want to get to that. Regarding multiple exposure, can you comment about the experiences of abattoir workers?
Well, look, that's an interesting one. Look, I don't think that they would, if you went to a clinician, the question is, would they satisfy the stressor criterion? And I think the answer would probably be no, but I can imagine there would be a lot of people who, might debate that. And look, I think another side of that is, look, I certainly know that vets are a group of people who, are very affected by having to euthanize animals. And that, they're a group who, as a consequence, are at sort of significant suicide risk. But look, I think it's one of the arguments for sort of humane slaughtering. But I think it's the people who actually have to kill the animals who are at risk, not the people who necessarily have to butcher them. But look, I think it's probably a job that doesn't go without its psychological cost. I think you would have to become numbed to a degree to work in that sort of environment.
So the next question that's come through is, how do you get to the baseline?
So I'm not quite sure what's meant by that question. I assume it's how do you recruit symptoms up to the diagnosis? Is that what's meant, do you think?
I'm not sure. Fareed, are you able to let us know when you say, how did you get to the baseline?
Because, well, look, one of the things I am going to do is to talk about how people recruit symptoms with time, because in a sense that really absolutely gets into the thing that I'm about to talk about here. The important issue is that people don't suddenly wake up one day with PTSD. Look, there are a group of people who will have some horrendous event and will develop an acute stress disorder. They'll develop dissociative symptoms. They'll immediately have all the nightmares and they'll have become very disorganized and hyper aroused. But the interesting thing is actually that's the minority of people. So, I assume that that's what that question is leading us to, which is really what we're going to talk to next about the importance of delayed onset disorder.
So yeah, it was in regards to the earthquake earlier on in your discussion.
Right. Well, look, the point is, well, I'll talk about that because, basically, with disasters, people often make the mistake, they think all the morbidity is going to be in the first few days. The evidence is not that at all. The evidence is in the second and the third year, but I will talk about that. And I think the problem is that so much of the effort that's put into counselling after disasters is completely misplaced, and it really is, as I was talking about before, it's a residual a consequence of this belief in the acute effects of stress being the critical issue, which was inherited from World War I and World War II. There was no focus on the long-term consequence. The belief was that if you minimise the symptoms acutely, there would be no long-term disorder, and that just was not correct.
Great. There's no other questions. Thank you, Professor.
Okay. Well, let's continue. So, look, the issue, one of the real debates in PTSD was, and this is one of the issues that you can see is a problem for insurers. If you don't, and after World War I, the interesting thing was the rates of pensions continued to go up as the years of the war into the past increased, and people said, well, there cannot be any link between these disorders and war exposure. But what we now know is that's not true. One of the issues here is that so often people do research that only looks at people for a brief period of time after these events, so they fail to look at the long-term consequence. Now, one study that I've been involved in has followed 1,000 accident victims. Some of them were from the Royal Adelaide Hospital. This was some colleagues from Victoria and New South Wales, and we followed this group of people over 6 years. And you can see here the most common pattern, and these people all had accident injuries sufficiently severe to get them into hospital. You can see that this resilient group makes up 73% of the population. So even in hospital, they've got no symptoms. This gets back to me saying, well, what is normal? Well, actually not having any symptoms is what's normal. Now, the most common trajectories are these two here. These make up 18% of people have got this increase of symptoms in the first 2 years. And many of them only reach the diagnostic threshold in this latter period. Interestingly, this chronic group, many of them actually, a percentage of them actually had disorders prior to the accident. And then there is a group who have acute symptoms. But the important issue is this chronic outcome, which is the more common. Now, what's really important about this, if you've got somebody who's had an accident or they've been assaulted, or they've been in a disaster, if your practice is in the Adelaide Hills or on Kangaroo Island, this is a thing you've got to keep looking for. Many of these people have literally very few symptoms acutely, and you might think everything's going to be fine. The point is that things progressively get worse with time in a significant percentage of people. Just to show that this is not an isolated finding, this is a study of American troops in a huge study called the Millennium Cohort Study. It's a study of 100,000 people that's been followed over 30 years, and they've got this, within that cohort, they had one population of people where they had a pre-deployment measure, a post-deployment measure, and a second post-deployment measure. And you can see this line with a 6.7%, you've got this pattern of increasing symptoms. That is the most common pattern. And we've had a cohort of Australian troops that we looked at pre-post deployment, and we had very few people coming back from deployment, even though many of them had very high combat exposures with significant symptoms on return. We followed them up 5 years later, and that's when the symptoms are beginning to emerge. Even the development of small increase in symptoms post-deployment was a significant predictor of that later significant increase. Now, this just shows how long this delayed onset effect goes on. There was an absolutely seminal study called the National Vietnam Veterans Study, which was first published in 1990. They followed this cohort up again 25 years later. And 25 years down the track, they found that 16% of people were continuing to have increasing symptoms, as against 7.6% were decreasing. So this is an effect that goes on for a very, very long time. It's not a short-term effect. Now, why does it happen? Well, one of the key issues, I think, is that in the aftermath of stressful events, people get disruption of of various biological systems, their homeostasis is upset. So you upregulate the inhibitory systems. The problem is that those inhibitory systems become progressively less and less effective at suppressing that reactivity. So with the process of time, you get sensitization. And I think this is one of the reasons why triggers are so important, because these constant triggers in people's environment that provoke people's anxiety carries with it that sort of physiological reactivity. So it's a feed-forward effect of kindling. And I think this is really what underpins this late emergence of symptoms and the worsening of symptoms with time. And, you know, this is something to really watch for very carefully in people because this doesn't occur acutely. It's something that happens with the passage of time. The other interesting point is that we know that there are a whole range of biological systems which have been shown to have this very issue with sensitization. And these are the sorts of the other neurobiological systems that we know are key to PTSD. We know that inflammation is important. We know that the glucocorticoid system is important. You know, we know that there's increasing sympathetic and autonomic reactivity. There's modified lipid metabolism. So you know, I think it is a key issue to observe and think about this process of sensitization. Which really brings this other question about the baseline and how you get there, and the issue of subsyndromal symptoms predicting disorder. Because I think there's a tendency, you know, if somebody doesn't reach a diagnostic threshold, you think, oh, well, you're fine. You know, you don't need to worry about that. You know, there's nothing wrong. You've just got a bit of sleep disturbance or you're not concentrating all that well. But the evidence is now that even those few symptoms are really of significance. And the ones to think about are sleep disturbance, affect dysregulation, some disvariance of mood, you know, things like an exaggerated startle response. If people start getting panic attacks, that's often about their response to triggers. So, and the way we would diagnose these generally is an adjustment disorder. But look, the issue is if you can stop this sensitization process early, you're much more likely, I think, to have an effective intervention. So if people are coming along complaining of these things, it's very easy to reassure people and say, well, this is normal after these events. Well, the issue, it's not normal. And if you do have these symptoms, you really should be doing something about it. And, you know, we know that if people have these sorts of symptoms and they're exposed to subsequent stress, that's a very significant predictor of subsequent disorder. And one of the things, particularly in emergency service personnel and military people, is if they have got these symptoms, you know that they really are at very high risk in the long term. And, you know, one of the obligations, I think, that it puts upon emergency services is to actually treat people with these early symptoms. You know, we know that in the Metropolitan Fire Service, we did a study, about 15% of those firefighters have got subsyndromal PTSD. Now, the Metropolitan Fire Service is very good about it. They have got a program in place, but the police do nothing about it. And, you know, if you really want to do something about police violence, you know, understanding how officers who are becoming anxious become more aggressive. So it's not just in the officer's interest, it's in the public interest, I think, to understand the significance of these symptoms. Now, just to show you the relevance of subsyndromal symptoms generally, because, you know, this is the sort of thing where in general practice, you're, you know, in an absolute box seat to make these observations. This is a follow-up study of depression and anxiety in a general practice study. And essentially what they could show that your probability of getting depression or anxiety could be mapped on two things. If you had no history and no threshold symptoms, you can see you've got the box on the left-hand side, you've got a very low risk of getting depression or anxiety 2 years later. If you've got a history and no sub-threshold symptoms, you've got a 15%. If you've got a no history and sub-threshold symptoms, you've got a 20% risk. So you can see actually sub-threshold symptoms are a better predictor of subsequent disorder, full-blown disorder, than having a past history. If you've got both a history and subsyndromal symptoms, you can see you really are at risk. So, you know, I think this really points to the fact that we need to take a much more dimensional perspective on people's reactivity and think about interventions for these lower levels of symptomatic distress. So just to sort of summarise the diagnostic issues here, one of the problems is that PTSD, there isn't a partial or a subsyndromal PTSD in the diagnostic criteria, and this attracts the diagnosis of an adjustment disorder if you've had no other disorder. But the thing is, it's an important diagnosis to make and to treat. The third thing I'd like to emphasise, if people have got those traumatic memories, you can see how it puts you at risk of depression, it puts you at anxiety. So a cognitive behavioural intervention that focuses on the traumatic memories is a very valuable intervention prior to you getting the diagnosis. If you can remove some of the fear and the reactivity with those memories, that has got a long-term benefit. And it's particularly managing the reactivity to environmental triggers to stop generalisation. Because one of the most important things to get people to do is to realise what's the difference between what's triggering their anxiety and the traumatic event that has led to the onset of their symptoms. And then I keep bringing the issue of somatic symptoms up, which I'll come to. So what I've summarised here is the importance of the longitudinal course and the importance of, this is a very, time and stress reactivity over time is a critical issue to think about here. The delayed onset PTSD is much more common than we've really ever anticipated. And with orthopedic injuries, for example, you need to follow these people up for a long time. They might have got over the injury, and then everybody says, well, why on earth have they developed PTSD? Well, or developed depression? Well, the issue is because that's the nature of the underlying psychopathological mechanisms. It's not because of compensation or whatever. And we were actually able to show in that study of accident victims whether you had compensation or not had no relevance to whether you got the diagnosis or not. These effects are independent of that. So those who have severe acute symptoms are a minority. So all of this focus, as I said before, about acute counselling is really a complete waste of time. Because those interventions that's been shown don't work. And it really is about monitoring the trajectory of people's symptoms. And if they're worsening, it's about how you intervene. The other really challenging issue here is that many people don't present for several years. And many people don't seek treatment at all. In the Australian community, the last National Mental Health and Wellbeing Survey showed that only about 40% of people with PTSD will seek care. That is, I think, one of the real challenges we have. And it's why I think in general practice, you have such an opportunity, because these people often will be coming and seeing you for other issues. And it's, even though the accident might have happened 3 years ago, it's to still, for you as the doctor, to keep thinking about, how this can have an effect. Just to give you an example of what can sometimes go wrong, some colleagues in London, after the terrorist bombings there in 2005, they wanted to do a treatment study of the people who had attended the emergency departments. And what they were able to do was to screen them all. They contacted them directly. Now, the interesting thing was that a number of these people who had PTSD had actually gone to their GPs, and their GPs were reluctant to refer them, because what they were saying is, look, the symptoms you've got are normal in this environment. And that's that problem. If you normalise the symptoms, you miss their significance. You miss the fact there's a whole group of people who don't have symptoms. So, I think it's having a low threshold for referral is an absolutely critical thing here. And this is what was shown not to have happened in the London general practices after the London bombings. So let's talk about this whole issue about the somatic manifestations, because I think this really is a fundamentally important thing. Now, I think one of the problems is that, we've split the psyche and the soma. And, I personally think that, there's a core disorganisation of autonomic reactivity in PTSD, which about environmental processing. And one of the things that does is leads to a whole set of somatic symptoms. Now, just to show you how common this is, and I apologise about the complexity of this slide, but if you can see all these somatic symptoms down the left-hand side, and you can see these are all, now this is a population of over 10,000 members of the Australian Defence Force. These were not a deployed sample, these were a non-deployed sample. And so we had around 340 of those who had PTSD. And you look at the prevalence of these symptoms like stomach pains, back pain, period pains in women, pains in their arms, headaches, chest pains. You can see that physical symptoms are almost ubiquitous in this population compared with those with no disorder. Now, the fascinating thing is, well, why don't we write these into the diagnostic criteria? And the reason why that's really important is because we know after every war that soldiers have complained of these physical syndromes, and they believe they're due to environmental exposures. You know, for example, after the first Gulf War, they thought it was the multiple vaccinations, depleted uranium exposures. You know, after Vietnam, it was Agent Orange exposures. So these symptoms are a major health concern. So the fascinating thing is, people with PTSD have those symptoms, so why don't we actually see them as part of the problem? Now, after Ash Wednesday, another study I did was of a group of firefighters, and you know, in those days you had much greater access to information, and we had the permission to go and look at their GP records. And the fascinating thing is that there were 70 of these firefighters who had PTSD, and we had a control group. We didn't go to all of those who didn't have PTSD. And you can see how they'd virtually all gone along to their GPs complaining of a range of physical symptoms. The interesting thing is only 3 of them had been actually diagnosed as having PTSD or a problem as a consequence of the fire. So the thing is, if you've had somebody who you know, for example, after the recent fires, comes along to you complaining of respiratory symptoms or gastrointestinal symptoms, it's absolutely critical you also think about, well, has this person got PTSD? Now, the interesting thing is, for example, the respiratory symptoms, what we've been able to show in that population of soldiers I was talking about is that you could actually measure changes in respiratory function. Now, they're not clinically pathological, but they do occur. We know that irritable bowel syndrome is much more common. You know, irritable bowel is about, you know, complex disruption of bowel functions, very, you know, significant neural plexus. Cardiovascular function, we know that there are disruptions of respiratory sinus arrhythmia in PTSD. So these people at some level can sense their disrupted physiology. And I think, you know, ignoring it is really at our peril. And just to give you, this is an example of just how common this is, and this is in a population sample in Canada. You can see there were 36,000 people without PTSD, 470 with PTSD, and you can see, you know, you've got asthma is increased, chronic bronchitis, and all of these pain syndromes. And again, you know, for physiotherapists, this is a critical issue. So, you know, and the really important issue here is that there is an underlying pathology that explains this. These people are not making this up. These are symptoms that actually do have a physiological basis. The thing is, it's not in the realms of pathology that we're used to treating with most of our interventions. So we therefore dismiss these symptoms, but these are problematic for the patients. So the interesting thing is that there is a shared etiology. And one of the things that we know, for example, is the circuitry of pain is very similar to the circuitry of PTSD, the neural circuitry. You know, we're talking here about the amygdala and the inhibitory circuitry within the central nervous system. And even in the endorphin circuit, endorphin metabolism is different in PTSD. And this brings us to another really interesting development in the field, because you can see you've got all of this non-specific physical symptomatology. So the question has recently been asked about whether PTSD is a systemic illness rather than a psychological disorder. And, you know, this is a really important question, because if we're going to develop PTSD, better treatments, particularly in the biological domain, do we need to take account of this physical morbidity? So what is the extent of the comorbidity with physical disorders? You know, is there a decreased life expectancy? And I've already outlined how somatic symptoms are an integral part. And what I'd like to show you is about how this is underpinned by systemic dysregulation of immune function and non-autonomic function. Now, one meta-analysis of a whole series of middle-aged adults with PTSD compared with the general population shows just how prevalent things like metabolic syndrome, hypertension, and hypoglycemia are in people with PTSD. there's increased rates of obesity. So there are significant consequences. The high rates of cardiovascular mortality, and a study that was a meta-analysis published in 2015 showed that if you've got PTSD, it takes 4 years off your life expectancy, and it should be seen as a systemic disorder because of the premature mortality. Another recent study was published in the Medical Journal of Australia really showed that it doesn't matter, and this has been shown in a number of other studies, it doesn't matter whether you're talking about cancer, whether you're talking about autoimmune disease, whether you're talking about cardiovascular disease, whether you're talking about pain, whether you're talking about epilepsy, you're talking about autoimmune disorders, they've got significantly higher odds ratios of prevalence in PTSD. Interestingly, kindling is an important phenomenon in the onset of PTSD, that sensitization process I was talking about. So it's not surprising that you get epilepsy. People with PTSD have a higher rate of epilepsy. And I'll talk a little bit more about rheumatoid arthritis. I mean, some of the genetic work that's coming out about PTSD is showing that the risk factors for, like the gene for rheumatoid arthritis and psoriasis, is a risk factor for PTSD. So I think this really begs this very significant question. Well, the underlying dysregulations of inflammation in these disorders, what are they doing to the brain, and how are they also impacting on somatic pathology? We know that there are high rates of dementia in PTSD. In PTSD, you have a decrease in total brain volume. We're coming to understand the role of the glia in central nervous system and their role in inflammation. So, I think one of the possible causal pathways here is that when you're exposed to traumatic events, this leads to a biological dysregulation that can either be manifest as physical disorder and/or PTSD. And there probably is a very interesting interaction between these disorders. And I think this is a really critical issue. It's one of the reasons why general practitioners, again, have got such an important role, because you can see if PTSD is a risk factor for these physical disorders, understanding and treating the person's psychological disorder is an integral part of it. Even if there's a psychiatrist or a psychologist involved in treating PTSD, you also need to anticipate that physical disorder. And it may mean that there are some, for example, antihypertensive regimes that might be optimal to both assist in treating the PTSD symptoms and the hypertension, for example, or the cardiovascular disease. So, look, I'll stop there and let people ask a few more questions before I talk about treatment.
So we've got a question from Julianne. Regularly, I find that parents who've had their children removed from their care diagnosed with PTSD, citing isolation event as the cause. How does this fit with the view that PTSD is over time?
Well, look, the first issue, I'm not sure what Julie means by isolation is the event that causes PTSD, because essentially you can't get PTSD from isolation. That wouldn't meet the stressor criterion. I think, tragically, many of the people who have childhood trauma, it has really very significant effects on their affect regulation and their capacity for attachment behaviours. And one of the things that often I think is a critical element to that. In fact, I had a PhD student, Jackie Beale, who did a longitudinal study of interviewing a group of mothers prior to them giving birth, and then followed them and their children up for 2 years. And interestingly, even if a mother had been trauma exposed and didn't have PTSD, the language development of her child was slightly delayed. And the reason is that because, if you've coped with a traumatic exposure, you probably have got a degree of over-regulation of your frontal circuitry, that loss, so you stop your amygdala reactivity a little bit. And that stops you reading, your child's expression and affect, which is critical to language acquisition. And I think in that cohort of parents who have children taken away from them, I mean, tragically, they often, come from that very environment themselves, and then have had very sort of dysregulated lives, and then have, those same sort of challenges of attachment. with the kids that then leads to them being removed.
So again, PTSD and borderline personality disorder diagnosed, what does it look like supporting a person with both of these diagnoses?
Well, look, I think it begs a very important question. I think the effects of trauma at different developmental stages have very different effects. Obviously the tremendous challenge with people with borderline personality is dealing with their difficulties with attachment and emotional regulation. So, like I'm going to talk about treatment now, but for people with borderline personality, obviously the critical steps with them are to form a therapeutic relationship. You've got a system in developing methods of affective regulation and control before you begin to address the trauma issues. Now, I think acknowledging the trauma issues is a very important thing, because I think one of the things that I've certainly seen it do in clinical settings, if you can get people to focus on that, I think it increases the empathy for the patient, and also allows the patient to have an empathy for themselves, which is often so difficult with the person with borderline personality disorder. I mean, I think one of the other challenges with that group of people is they often have a lot of sort of dissociative type symptoms. And so one of the other very early strategies is how to assist in grounding techniques, etc., before you get into the more sort of detailed aspects of the treatment of PTSD.
Thank you, Professor. So the next question was, you spoke about addressing the symptoms early to avoid sensitization. I wholly agree, but I find it difficult to do with those involved in medicological work cover processes because of the ongoing stresses. How do you address this? And are there specific symptoms you focus as priority due to time constraints?
Well, look, I think sleep regulation is, I think the whole workers' compensation process is a very difficult one. There's no doubt about it. There are a whole group of people who haven't got into that circumstance where you can begin to tackle these issues. But look, I think the first one really is sleep disturbance, and there's some very good cognitive behavioural programs for sleep disturbance. I think we were able to show in a study of people's glucocorticoid systems and biological rhythms in the first 24 hours after accidents. The people who develop PTSD have got lower levels of melatonin. So, one strategy, that's worth trying with people with PTSD is to use melatonin as a sleep agent. If that doesn't work, even low-dose amitriptyline, I think, can be very helpful. I think that's one strategy that's really important. I think giving people a strategy for dealing with the triggers very early is a very important thing. Getting people to understand them, how to have strategies for differentiating the triggers, how to not develop a pattern of avoidance, to understand the principles of exposing themselves to what's triggering their symptoms. But doing that by seeing the difference between the trigger and their symptoms is a very important thing to do. So, that would be, I guess, the two places that I would initially, I think, put a lot of my energy.
Right. So Julianne's come back with the question that she asked about parents having their children removed. She said parents of the removed children, not children who were removed from their parents, that they were diagnosed after their children were removed, not prior.
Right. Well, look, I don't think you get PTSD from your children being taken away from you. Look, I think this really gets into this whole challenge about what is a traumatic event and what isn't a traumatic event. I don't think that's a very different, it's a tragedy and it's an attachment trauma, but that's a different sort of trauma. Now, that's not to say that, what I've been talking about tonight about trauma hasn't got value in understanding that reaction, but I think the way you need to treat it is sort of a very different issue. But I would think that those people often who have their children taken away, I suspect that, you know, why I answered as I did before, is that I suspect in the background there is that sort of history lurking as I was describing.
Thank you, Professor. There's no further questions.
Okay, well, look, let me just move on to treatment. And look, it's in some ways simple, but in some ways complicated. Look, I think the first thing is Freud, you know, got the trauma thing wrong later in his career, but he wrote this wonderful lecture with Breuer in 1896, and I think this is just to sort of gets to the absolute nub of the issue. That trauma does not simply act as a releasing agent for symptoms. Rather, the psychic trauma, or more precisely, the memory of the trauma, acts like a foreign body, which long after entry must continue to be regarded as the agent that is still at work. Now, you know, what I described about those traumatic memories in those kids after the bushfires and the way they put you at risk of depression and anxiety is absolutely what Freud said. So what did he say about treatment? And we should call it traumatic symptom. Each individual hysterical symptom immediately and permanently disappeared when we had succeeded in bringing clearly to light the memory of the event. So, you know, I have been talking about how people sometimes don't make the link, for example, between a trigger, like the man who was buried in the trench, and the trigger. So, you know, what you've got to do is to get him to focus on the memory of being buried, by which it was provoked, and in arousing its accompanying affect. So the point is, it's to get him to also identify the emotion that he had in that memory. So the emotion is an emotional memory. And then what you do is get the patient to describe that event in the greatest possible and put the affect into words. Now, so, you know, people often think about, you know, the whole idea of catharsis, that you've got to get the affect out. Well, no, it's not about getting the affect out. It's about linking the affect to the memory and using language, because Nietzsche, the philosopher, who'd actually been an ambulance officer in the Franco-Prussian War, said that of which we speak is that for which we have contempt. And, you know, there's a fascinating issue that if we, you know, language is a higher form of symbolic representation of experience, and in some ways we sort of strip the affect out of experience when it's expressed in language. And that's really what the aim of treatment is. Now, you know, this has been called many things, and the cognitive behaviour therapists will call it cognitive behaviour therapy. But you can see cognitive behaviour therapy is exactly really what Freud was describing in 1893. And I think, you know, that sentence tells you what you have to do. So it's identifying the memory, what's the emotion associated with your memory. And look, I think we really don't understand the range of emotions here. You know, horror, for example, is a very intriguing memory, a very intriguing affect, which I think we deal with very poorly. You know, disgust. You know, there are a whole range of very complex emotions people have here. And then it's about staying with the patient and helping them really dissect the experience and find a language for it. So, treatment guidelines. In fact, the NHMRC today have just certified the most up-to-date version. The last version was published in 2013. These will be available in the next week or so. And the recommended treatments are essentially cognitive behavioural therapy or prolonged exposure, rapid eye movement desensitization or EMDR, and antidepressants. Now, that sounds incredibly simple and incredibly boring in a way, but the important issue is that you do have to make sure, I think, that if somebody goes to see a clinician, that they actually do one of these techniques, they use one of these psychotherapy techniques. You know, because so often people get supportive counselling. Now, that's not to say that supportive counselling isn't of benefit. And look, and I will sort of contradict myself, but look, I think it's one of those things where it's so important to give people a chance and to make sure that the people you're referring to actually do use these techniques. Another important recommendation in the guidelines is about screening. Now, you can see from what I've been talking about, the challenge is diagnosis. And I think, you know, like if you know that you've got a patient who's been in a motor vehicle accident where there have been significant injuries or, you know, somebody's been killed, you know, it's just every now and then coming back and going through a few key screening questions. You know, is this event still playing on your mind? You know, are you avoiding things that remind you of it? do you find yourself, withdrawing, not enjoying things, feeling numb, being socially withdrawn? Are you not sleeping well? So you can either do that or have some sort of simple sort of questionnaires which you can use in practice. I think the other thing is that it's so easy just to talk about what treatment should be given, but I think the other part of this is 30% of people who drop out of these standard treatments, and it really is about how you help the patient understand the significance of their symptoms. And look, we also, I think, underestimate the importance of psychoeducation. I did a treatment trial comparing CBT and EMDR on one occasion, and we're able to show that 30% of the benefit of the intervention happened in the first 2 sessions was actually simply about psychoeducation. People, if they can understand what's happening to themselves, people are often very good at developing their own strategies for managing it. So, spending time explaining to people what's going on is a very important part. And I think we often minimize, the significance of that process with the patient. It's not just sort of telling them they've got a disorder. It's actually telling them about the dynamic process that underpins their symptoms and how these different parts of it all fit together. The other important issue is that, I think in psychiatry, we too often sort of focus on removing the symptoms in the diagnosis, but forgetting that function is the critical issue. And I think so often, and this has been shown in the depression literature, that people's symptoms improve, but often their function doesn't change. And one of the issues is that people who've been unwell often become very frightened of becoming unwell again and almost sort of put themselves in cotton wool. So one of the critical issues in the context of the evidence-based treatments is about helping people re-engage with their life. And I can't sort of overemphasize that enough. Now, the other important thing to face, and I think this is actually, I think, look, I've been part of doing treatment guidelines. I've been involved in all the treatment guidelines in Australia and some here overseas and the International Society. And I think there's a danger sometimes in overselling the treatment guidelines, because what you don't do is acknowledge the need for improvement of treatments. Now, just to make this point, in a meta-analysis of cognitive processing therapy or proximal exposure and prolonged exposure in PTSD showed that despite there being significant clinical improvement in 49 to 70% of patients, that between 66 or around 66% of them are left with a diagnosis after treatment. Now that doesn't mean they're better. If you had angina and you went to the cardiologist and 2/3 of the patient were left with angina, even though it might be a little bit less severe, people are not going to be happy, and so we've got the problem linked. And I think we really do need to be more critical. And I think the benefits of cognitive behavioural therapy and prolonged exposure, in contrast to non-trauma focused psychotherapies, is sometimes overstated. And there was a meta-analysis that was published in 2008 that didn't include waitlist control, for example, because if you've got a waitlist control, you always get a larger effect size than if you have an active treatment. And this showed that if you only looked at the treatments for studies in PTSD where you had an active treatment compared with CBT, there was no difference. And this caused absolute rage in the CBT community. But I think it's a very important point. I think one of the things that we don't talk about enough is the conflicts of interests in the people who are on guideline committees, particularly those who are basically teach and research psychosocial interventions. And if you had the chairman of Pfizer as the chairman of a treatment guidelines committee, I think there'd be a few questions asked. But if you look at who writes treatment guidelines for PTSD, some of the most sort of vociferous advocates of particular treatments have been the chairs of those guidelines committees, which I think has actually confounded a little some of the conclusions that have emerged. And just to give you an example, the role of medication tends to get talked down as a second order treatment. What's often ignored is that the very significant majority of trials that have ever been done of CBT have been many of those people are actually on medication. So they've actually been stabilised with medication before they get put on, they're given psychotherapy. Now, this is the only trial that's actually directly compared prolonged exposure with sertraline and their combination. And it actually showed that enhanced medication management, if anything, did slightly better in the long term than prolonged exposure. So, you know, and the NHMRC, for example, would say that these are the trials that you really should be referring to in your guidelines. So, you know, while, you know, the treatment guidelines will say that medication is really a secondary treatment that should be used only if you've got severe depression or somebody can't have CBT. In fact, a trial like this, which was published in JAMA Psychiatry, so it's not no slouch to get a paper in there, you know, highlighted you know, that in fact, you know, medication can be a very real option here. The other important issue is that treatment guidelines don't ever discuss the issue about severity as a predictor of treatment response. And there was an interesting meta-analysis that was published in the Clinical Psychological Reviews in 2015, which has got a curve like this. So essentially, if you've got very severe PTSD or you've got very mild symptoms, you actually don't get nearly as big an effect size as if you've got moderately severe PTSD. Now, you know, I think one of the things that we haven't been good at doing is really trying to tailor the treatment to the patient. And you can see, you know, you immediately might see that, well, if you've got somebody who's very severe, well, that's why you might try, you know, medication strategies and non-trauma focused therapy strategies, because things like affect regulation might be more important. And I think one of the other things that we really need to do in psychiatry is to actually think about the issue of staging. And one of the papers I've sent you is about this, because you know, what we don't do, I think, in treatment, we assume that it doesn't matter whether you've had the disorder for a week or 5 years or 10 years, that the treatments are all going to work the same. And look, that just is illogical. I mean, we know in disorders like depression, the duration of illness is a critical determinant of outcome. And what I would argue is that we really need to have a staging model here. And one way of thinking about staging is you're trauma exposed. Because, you know, I showed that if you've got trauma exposure, you are at greater risk with further exposure. You know, you've got the minor symptoms, you've got subsyndromal symptoms, you've then got your first episode, then you've got a relapsing or more enduring disorder, which is relapse following treatment, and then you've got the chronic severe disorder, which is treatment unresponsive, where you may have a whole lot of medical comorbidities. And you can see the way you need to treat each of these phases is very different. But at the moment, we're not good at really, I think, differentiating how they should be different. And I think, you know, this is one of the reasons why, you know, I think what we really need in Australia is to have centres of excellence that, you know, for example, take on the patients who are relatively treatment unresponsive and then have a very systematic protocol for going through strategies about how you can personalise the response and see if you can predict, you know, using a whole range of neurobiological assessments and psychological assessments to see whether you can predict which patient populations might do better. And I'll just give you an example in a minute about why, of how we might go about that. So, you know, the importance of progression, staging, is that it's about the emphasis on progression and transition. And, you know, I talked about that in terms of longitudinal course. You can see why, you know, a staging approach makes so much sense, you know, when we think about this disorder from a longitudinal perspective. You know, if the more we can get treatments that work early in the disorder, and it gets back to the whole issue of screening and why that's so important, you know, why this should be a strategy in emergency service personnel. You know, this is just like what we do with cancer. It's no different. You know, the other issue is about, you know, how biomarkers might change at different points in the disorder, and I'll talk about that a little in a minute. So it's really about having different treatment strategies at different stages. And I think, you know, this is an area where the field, I think, is very undeveloped. So what might be the new directions? Well, look, there's some fascinating little indicators. Angiotensin receptor blockers ameliorate brain inflammation. Now, you know, does that make a difference? Is that relevant? Well, I don't know if you know that if you block your angiotensin system, you've got better mental health. And this has been shown on a population level. You know, so there are some interesting inroads into effect. And this gets down to, you know, if somebody has PTSD, early PTSD, should we be thinking about putting them on low dose of one of these drugs? You know, this is a very real question. So, and one little sort of insight in this really is this question: does addressing systemic pathology impact on treatment? Now, with C-reactive protein, this is a study that looked at C-reactive protein, and we're talking about low levels of C-reactive protein. We're talking about anything, above 1. If you've got a slightly raised C-reactive protein prior to being deployed as a soldier, you've got a greater risk of PTSD symptoms on return. So underlying inflammation is a predictor of your risk of PTSD. Now, one of the interesting things that most people are unaware of is that the antidepressants are actually anti-inflammatory agents. The serotonergic system works on cellular immunity, and the noradrenergic system works on humoral immunity. Now, does that impact on whether drugs have their antidepressant effect? Now, one study basically compared an SSRI with an SSRI with plus bupropion, which we can't use in Australia, but that's a noradrenergic agent. And what it did was simply define people around having a CRP of less or greater than 1. Now, you know that that's way below what we would see as being pathological. And with the full sample, you can see it didn't look like there was any difference between those regimes. But interestingly, if you had a CRP of less than 1, you responded better to an SSRI, whereas if you had a C-reactive protein of greater than 1, you responded better to bupropion plus an SSRI combination. Now, this is a study that's begging to be done in PTSD. We know that inflammation is a critical element of PTSD. We've studied this in this cohort of soldiers prior to following deployment. In fact, it's the loss of stress reactivity is the issue. And these are drugs. Now, do antidepressants have interesting effects? Well, in Sweden, there's a disease registry where they basically, have diagnoses like PTSD, and they look at the risk of subsequent autoimmune disease. I mean, the most common autoimmune disease after PTSD is Hashimoto's thyroiditis. Actually, I saw a patient with that this week. Now, the interesting question if you're on antidepressant, did that have any effect? Because they can also match their pharmaceutical records to their disease register. In fact, it halved your risk if you were on an antidepressant of developing an autoimmune disease. So the anti-inflammatory effect of antidepressants has a benefit to people with a stress-related disorder. And, I've had patients, I'll never forget one woman who had PTSD, whose mother had crippling rheumatoid arthritis. And I said to that woman, look, we know your genetic risk is, you have a genetic risk for rheumatoid. We know that PTSD is a risk factor for rheumatoid, but an antidepressant will benefit you. So, I think these are the sort of domains where, GPs are absolutely front and center of the management of these sort of risks. So, conclusion, PTSD is a disorder that has multiple stages, and treatment needs to be based on an investment of individual pathology, not one size fits all. We need to be developing more effective biologically based treatments that are supported by the evidence and that really are tied to what we know about the neurobiology. And using that staging model, the timing and intervention may be critical to the effectiveness. Something may work at one point. It's like breast cancer. The treatment is different at different stages. And I think we should be thinking of psychiatric disorders in that way. Just to sort of bring it all back together, let's not forget about psychotherapy. The real issue about what Freud said was about the limitations of language in conveying traumatic experience and the need to use language to capture the experience. It's one of the reasons why patients are often have difficulty speaking about their symptoms. Speechless terror is what we talk about. I've tried to highlight for you the importance of talking about and identifying traumatic memories, because these, like a risk factor. Understanding the triggering of distress, which is central to sensitization, which is absolutely tied to the neurobiology, but something that, you really can help patients manage. And the other one is, linking the psychological and the somatic distress. These are all part and parcel. This is an experience both that affects people's minds and bodies. And to think of it just as a psychological problem, forgets how the physiological dysregulation of stress is equally part of this condition. And that's what patients worry about. That's what they come along and see doctors about. That's what they want to have treated. I think it's a very difficult sort of conversation sometimes to explain to people, but, to help them understand about autonomic dysregulation, and how that's really driven from brain systems is critical. So I think what we've learned is that individuals who've coped with times of stress can become very unwell many years later, and that's something that's been tremendous difficulty. The 20th century is about the struggle to actually get people to accept that. I think one of the problems was that we didn't have models of psychopathology to explain this, and I think it's why sensitisation is such a key issue. And really, staging is a way of, I think, the staging model is a way of really bringing all of this together. So one of the critical dimensions with this is to think about time and the progressions with time and the difference in treatments at those points. And just going back to the beginning about the health systems, see, one of the things is that, we have different health systems that deal with car accidents, victims of crime, the military, rape victims, child abuse victims. There are different services here. When a disaster happens, we have to constantly recreate a service for disasters. And then we have our mental health services, which I think are totally under-resourced and ignore the issue of psychological trauma. And one argument is to try and improve the assets and skills of our mental health services more generally in trauma. In fact, the mental health commissioner in San Francisco, who I went to Kobe, where there was an earthquake, said that one of the things they've done in San Francisco is to teach all of their mental health clinicians trauma-informed care. And what they so that when there's an earthquake, they actually have a mental health workforce that can assist in the population's difficulties more generally. But then one of the things they found, though, was that dramatically improved the treatment of all their patients with bipolar disorder and schizophrenia, because suddenly the clinicians became interested in these people's lives and what they needed. So, look, I think one of the great difficulties as a GP is that we live in a very fragmented system, and there aren't centres of excellence that really, provide services. And I've spent my professional career trying to, as have others, to get this recognised, but it's a constant struggle. And I think the downsizing of DVA has been a major loss in terms of having a culture carrier for the trauma field in our community. Thank you.
Thank you so much, Professor. I've got two more questions that have come through, or a few more questions. So the first question that's come through is from an anonymous attendee. The legal profession intervenes in PTSD and birth trauma in litigated cases, in particular in ways that are even more destructive than the original trauma, as it is about discrediting the memory and expectations, etc., of the traumatized person, especially deeming the pregnant woman with labels of baby brain and dismissing birth in particular as not a PTSD event. Stripping the effect out of the experience, what can we do about this?
Look, look, I think that the legal profession can be extremely difficult and challenging and destructive for people. There's no doubt about it. And, I think if the legal system were to be redesigned today, lawyers would never be able to do and say what they do to litigants. Would be deemed completely unacceptable practice and speech. That really is an aside. Look, I think to answer the question about birth trauma, look, there's no doubt that if a woman has a horrendous obstetric experience, for example, being awake during an anaesthetic, or severely exsanguinating, or a child dying, these really very much fall into the purview of PTSD, and people do rightfully seek reparation through the courts, and I look, and I think it's very difficult to really know how to protect them from it. I mean, one of the things that I personally do is to say to people, look, this is an extremely personal thing for you, but the issue is, as much as you can, try not to listen to the detail of the argument. That's why you have a solicitor, and why you have your expert witnesses for you to make those arguments, and to try and get them to depersonalise the process as much as they can. But look, it is, look, I think the legal profession is in some ways quite reprehensible. But I guess that could be the subject of a long discussion and another night's seminar, I suspect, about if we were really going to reform this, what we should do. But the other side of it is that actually litigation does matter. I mean, I was once asked by a registrar what was the thing that I'd done in my life that made the most difference, and actually, I said to them, well, actually, it's being involved in litigation, because I can go and knock on the front door of the Health Commission or the Department of Health as often as I want to, and I can tell you nothing happens until they start getting sued about it. And when they start getting sued about it, suddenly what was in the bottom drawer and that's been suggested, they start doing. So, I think legal accountability is incredibly important. I think that the challenge and the difficulty for people is the process.
Thank you. So the next question is, do the treatments actually resolve the PTSD fully and permanently? This is not what the article we have been given to read suggests. Have we any neurobiological evidence that the circuitry changes for neuroplasticity?
Yeah, look, a very interesting question. Look, and again, I hope my talk hasn't been too gloomy and the papers I've given you aren't too pessimistic. Look, there's no doubt there is about 30% of people will have a very good outcome. Not necessarily with cumulative trauma like war veterans. And there is a body of research which does show that things like the disruption of executive function improves. And that also improves with antidepressants. I mean, we've done some work looking at event-related potential studies and attentional processing. Those things certainly, are rectified and normalised by treatment. But the point is that it happens in a subgroup of people. And I think really what we need to try and work out is, well, what are the differences in the people who get that good response from those who don't? At the moment, we just keep giving them more of the same, rather than really asking that second question and really trying to characterise, what has been the failure of that treatment. And I think it's the difficulty when therapeutic schools sort of oversell their product.
Thank you. So is there a good screening tool for PTSD and assessing severity?
Yeah, it's a measure called the Post-Traumatic Symptom Checklist. I can send you through a copy of it. It's a 17-item question. There is also, a shorter version that can be used as well. So, and look, there's the National Centre for Post-Traumatic Stress Disorder in the US has got a whole battery of measures you can download off the web that people can use. So yeah, look, there is it's a very well validated questionnaire, and we've got some vast body of normative data on Australian populations. We used it in a study of the entire Australian Defence Force, so we know very well how it performs, and we've worked out the cut-offs.
So there's another question: is there a role for prazosin?
Yeah. Look, prazosin is an interesting one, and look, there's a mixed literature about it. It's been suggested, it's an alpha blocker, that it's been helpful in treating the sleep disturbance of PTSD. The trials have shown variably that it is effective, whereas others have shown that it isn't. So it's not a strongly endorsed treatment. But look, I think from first principles, I think it's one of those treatments that's very worthwhile using if people have that strong pattern of autonomic reactivity. So and I think particularly if people wake up from nightmares in a very high state of arousal, you know, it's a drug that has value and benefit in those circumstances. And again, it's that issue, particularly for a patient who has hypertension. You know, it's worth adding it, I think, into their hypertensive regime and see what benefits it might give.
Thank you so much, Professor. I'm sure everybody would agree it was a really interesting discussion and education session that you've delivered for us. And we really appreciate the time that you've spent on putting this together. We'd also like to thank Leo for assisting with it too. So just to close this evening, I thought I'd just quickly run through some information with you in regards to the health pathways for mental health. I've included the slide here and we can certainly send it out for you. So if anybody is interested in having a look at the health pathways that's put together by the PHNs, I can certainly share the health pathway slide with you. I'd also like to take time to thank Professor McFarlane for the presentation and express our thanks to Adelaide PHN for funding this event. There is a 2-minute evaluation for tonight's webinar that will follow on after this link, and we'd ask that everybody please fill out the evaluation form, as it's really important for our education to be able to do quality education events. Thank you very much to everybody for your attendance. We look forward to welcoming you all back on our upcoming future events. Thanks so much.
Can I just make one last comment? Look, just talking about the PHNs, one of the things that people should realise is, in fact, there have been some special bushfire clinician positions created after the bushfire. So if you're working in the bushfire zones, you know, the PHNs are an important source of information. And the local GPs are familiar with that, but it is something to be aware of, because I think one of the things that people forget about with the bushfires, there are a lot of people, particularly in the Adelaide Hills, who attend general practices in the suburban area rather than the hills. So it's important for people to know that facility is available for people affected by the bushfires. Look, and I'd also like to thank you also very much for, it's rather impersonal, and I hope you've had a nice couple of glasses of wine and the fire's nice and warm and you've got something good to do after tonight. So look, thank you for letting me spend the evening with you.
Thank you. Good night, Professor.
Bye-bye.